Good morning and welcome to Day 2 of the HIMSS and Health 2.0 European Digital Conference and Exhibition. I'm Sarah McGeet, your host for this week. After a busy and engaging day yesterday focused on COVID-19, this afternoon's main conference sessions look at how to turn data into action, and we have another very exciting lineup. But before we start this afternoon's main programme, we kick off in a moment with the first of two pre-conference sessions. The first is our workshop on clinician burnout, and the second is a masterclass on telehealth implementation. Statistics say an estimated 22% of physicians in the USA and 27% of physicians in the UK are suffering from burnout, and most European countries show similar rates. This not only affects the health of clinicians, but also has a big impact on patients and on health system productivity. COVID-19 has only put more demand on an already stressed workforce. In this workshop, we'll discuss how to create an approach to digitization with the workforce at the center of decision-making, and look at technology as a way to address some of the major contributing factors which lead to burnout. This session is sponsored, with great thanks from us, by Nuance. Nuance Healthcare Solutions capture, improve, and communicate more than 300 million patient stories each year, helping more than 500,000 clinicians in 10,000 global healthcare organizations to drive meaningful clinical and financial outcomes. Be sure to stop by their booth in the exhibition hall this afternoon. Let's now join the session for more.
Good afternoon, everyone, and welcome to HIMSS and Health 2.0 European Digital Conference. Thank you for joining us today for this session on addressing clinicians' burnout, creating a workforce-centric approach to digitization. Please remember that you can join the conversation via Twitter using the hashtag HIMSSEurope20. Without further ado, please welcome our moderator, Dr. Charles Alessi, Chief Clinical Officer, HIMSS United Kingdom. Over to you, Charles.
Thank you, Lisa, and good afternoon, everybody, and welcome to HIMSS and Health 2.0 European Digital. Thank you for joining our session, which really is all going to be about addressing clinical burnout, creating a workforce-centric approach to digitization. We know exactly how difficult the issue of burnout is, and I'll be alluding to that. But first of all, and I think most importantly, let me introduce the panelists. So let's start with you, Simon.
Thank you, Charles. I am the CCIO for Nuance Healthcare. They're a global organization that provides cloud-based AI-powered speech solutions to support clinicians with their clinical documentation. I've worked as a hospital doctor, GP, and public health doctor, and after spending a year at the King's Fund in London, I've spent the last 15 years in the digital health space, working in a wide range of different areas, including electronic health records, telehealth, mobile health, and lifestyle devices.
Thank you. Over to Helen.
Hello, my name's Helen Jives, and I'm in the lead nurse for clinical IT at University Hospitals Birmingham, but my official title is Chief Nursing Information Officer. My clinical background is that I'm an intensive care nurse, and I've spent about 25 years working in the intensive care units in various trusts. I joined the IT team as a clinical nurse because being in intensive care, we were very technology driven and very advanced. It was a 100-bedded ITU, so the biggest ITU in Europe, and we relied on technology a lot, and I felt that I had a good place for it in my mind, and I could adapt to it quite well. So I joined the trust into a new role as the lead nurse for clinical IT, trying to be the bridge between the clinicians who knew what they wanted in an IT system and the IT geeks who knew how to develop what we wanted in the IT system, just to make sure that what we did was fit for purpose in the clinical field. University Hospital Birmingham is a very big trust, it's 4 hospitals, and we are very technology advanced, so for me it was the perfect post.
Thank you. Felix.
Oh, thank you very much for having me. So from my background, I'm a computer scientist and a anesthetist, and in fact I did my residency training at Charité Hospital in Berlin, Germany, where I'm now currently serving as the Chief Medical Information Officer. at Charité, I'm also working as a professor for e-health and shared decision allocation. So I'm teaching medical informatics to medical students and computer science students.
Thank you. And Frederick?
Thank you very much. I'm Fredrik Johnson, and I am a CMIO in the county Skåne of Sweden, where I'm responsible for the implementation of a new EMR system that will have effect on around 30,000 employees. My background is as a trauma surgery, and the last 8 years I worked with leadership, and the last years with digitalization and leadership. So it's very exciting to be doing this panel. Thank you.
Thank you. And I really feel quite at home because my background is primary care and I was also an anaesthetist and in public health. I'm really amongst friends here. So thank you, panel. Now let's really introduce and frame the subject, because today we have something really important to talk about, and that is burnout. And we know what burnout is. It's now the word and the phrase which people are using more and more, the emotional exhaustion we're seeing in our workforce, elements of depersonalization, which we're seeing, and the reduced personal accomplishment, which is really what characterizes this whole situation, which then, of course, leads to those negative effects upon patient care, increased levels of errors, and for the individuals themselves, decreased self-worth and care, and all that comes with it. We were really working in a world where there was practically an epidemic of this. And really last year, we're talking about this affecting over 60% of physicians and nurses, I might add. This isn't only physicians, it's the physicians, nurses, pharmacists, and a lot of people who work within health and care. And so this is something which was having a significant effect. And of course it was having a significant effect because all this was driven by the fact we're having to cope with multimorbidity. We're having to cope, by that meaning the number of pathways we're going to have to cope with in terms of managing optimal care for an individual, having to cope with the loss of control or the perception around the loss of control associated with the consumerization of healthcare, and in many respects the less than perfect implementation of health and care EMRs, which has taken place certainly over the years in the past. And of course, over that, we add two other aspects. One, the workforce itself and the aging of the workforce, because we know that as the population's aging, the workforce is aging with it, and that has an effect. And then, of course, came COVID. As this wasn't bad enough, now we have something else which is influencing burnout, and influencing it really quite significantly, because the additive factor of COVID, the pressure, the workforce issues, the long hours, and all of that put together, and the increased complexity of the pathways that has caused, and the enormous administrative load as a result, has really now made this front and center of what a lot of health systems are spending their time thinking about. So it's just the right time, I think, for us to start talking in terms of what this means and what potentially, what effect this could have upon the care of individuals. So it's something which is really quite significant. So let's move on to the panel now, because I'm going to ask you some questions, and I'd like you, please, to keep your answers relatively short. And if I appear to be rude by interrupting you, it's not because I am rude, it's really because I'm worried about the time. So let me start with you, Simon, because I'm going to start with what I just talked about, the administrative load, really. And there are many reasons why the administrative load is a particular problem and really contributes quite significantly to burnout. What are your views around this? Because you've done some work around this anyway.
Yeah, you're right, Charles. I mean, there are many reasons why clinicians have been faced with increased administrative loads. And a key one of those is the necessary chore of clinical documentation. And as you said, over the last 15 to 20 years, healthcare has become much more complex. And Sir Cyril Chandler summarized it beautifully way back in '98 when he said, medicine used to be simple, ineffective, and relatively safe. Now it is complex, effective, and potentially dangerous. And with our experience over the last 5 to 6 months with COVID, this has been well demonstrated. The consequence of the cytokine surge, the abnormal coagulation and micro blood clots in the lungs, the miracle of dexamethasone, it's all needed necessary detailed clinical documentation. And of course, COVID is just one example. The key point is that healthcare has just become more complex, and the quality required for clinical documentation has become a key part of a health professional's day. So this is really important, but this excessive admin burden is one of the many factors that has contributed to the stress and burnout of clinicians. And as you say, I'm not just referring to doctors, it's nurses, AHPs, social workers, all healthcare professionals. A survey back in 2018 by Queen's University in Belfast, they found that 47% of doctors stated that too many bureaucratic tasks, such as note-keeping and paperwork, were contributing to burnout. And we did a survey a couple of years ago trying to understand how big a challenge clinical documentation was. And we found that clinicians spend around 11 hours per week creating their clinical documentation. And that's admission notes, ward round notes, discharge summaries, etc. But about 2/3 of that could be narrative. So that means lots of typing. We also looked at the wasted time clinicians spent searching for information that wasn't available or sufficiently clear at the time it was required. And that added up to around 50 to 70 minutes per day, more for doctors than others. We also looked at accuracy and completeness of documentation. And 1 in 4 clinicians felt that the level of detail they needed when reviewing the notes was not available. So if on top of creating notes, you include the time spent searching for information, reviewing the information, and often duplicating data entry, it's estimated that over 50% of a clinician's time can be spent on clinical documentation, which means they're spending around about 13% of their day actually interacting with patients. So in summary, clinicians are overwhelmed by clinical documentation, and as the Belfast study quite clearly pointed out, it's a significant contributor to unnecessary stress and burnout in the workplace.
Absolutely, thank you. I mean, this really has framed this discussion beautifully. So I'm moving now to Helen. Helen, I mean, you, as you said, you are responsible for an awful lot of people working on the front line, and you work on the front line. And really, what is your experience of seeing this in practice?
I think that the probably overwhelming word that the staff would use is fear. I think it's fear for themselves because this is all very unknown, and if this is a new job, a new role, a new world that they're working in. Fear for the welfare of their patients, fear that they'll make a mistake, fear of the unknown. They're doing 12-hour shifts. It's a very long time to be fearful for 12 hours, and then you go home and you're anxious about going back to work the next day or your next shift. There are external pressures put on the staff to be able to deliver the care in unknown circumstances. There are public expectations. You know, the world went out and clapped for the NHS, but actually that's just a demonstration that they have expectations on us doing a good job and doing it safely and doing it to the best of our ability. There's fear of litigation. We're in a different world from the point of view of being held responsible for our actions. I don't disagree with it, but it does make a different feeling. I was part of the setting up of the Birmingham Nightingale Hospital, and we were given freedom to have exceptions to the rules, and that took away some of that fear to a degree, and that we were given a degree of freedom to stretch the rules that normally the NHS has to comply by. But it didn't last very long, and now that we've moved on from the first wave, the public will expect us to have all of those rules back in place. They will expect us to do the targets. They'll expect us to not have pressure sores. They'll expect us to deal with complaints. They'll expect us to meet all of those targets. And yet we're still dealing with an unknown, COVID is very unknown, and we're learning as we go. And, we don't get any warning in healthcare. The teachers complain maybe they didn't have warning that the children were coming back to school, but healthcare had no warning whatsoever to deal with this.
Yeah.
And we were just expected to get on with it, which, we laugh about it, but it's the truth. And yet we were still expected to do it in a knowledgeable, confident and, in a caring way. And it's quite hard. And I think that's what the staff feel that they have to deal with. They're expected to manage the elective work. They're expected to deal with the emergencies. They're expected to keep it all within budget. We've got winter coming. We've never had to deal with social distancing, which we all know impacts on the volume of patients we can see. And we work and live in old hospital sites. That's not going to improve. And it's very difficult to try and deal with what's here and now and move forward.
I think you've described that absolutely beautifully. I mean, the fact that we, globally, we are having to take care of our COVID populations and not ignore our non-COVID populations, because people won't stop having heart attacks, strokes, deterioration of their non-communicable diseases. And we know in Europe, more than anywhere else perhaps, the risks of taking our eye off the ball there. We've had too many excess deaths in Europe as a whole. As a result. So you bring out all these important points, which really make it quite clear why somebody is feeling particularly stressed at the end of every day. And it's, I question as to the people who aren't suffering from burnout, is something wrong with them? Because we all would be feeling quite stressed in that situation. So thank you for really bringing that to life. Let's move to Berlin now, because Felix, in Berlin you had a somewhat different experience. You were fortunate enough in Germany to have an enormous infrastructure anyway, and in Charité more than anywhere else, of course. It's a wonderful hospital. And you were really making really quite significant progress in terms of digital transformation. And to an extent, COVID has accelerated that, because the issues around uptake of digital modalities in Germany have accelerated really dramatically. And I've actually seen this. We've been talking about this recently. All the issues around GDPR not making anything possible actually has changed and is changing. There's a new air in Germany around this. But I really need to ask you a question around IT. Why do people see IT as a significant and major contributing factor to clinician burnout?
Yes, you're absolutely right. And I mean, in fact, with COVID-19, we had a tremendous push when it comes to information technology. And I'm really proud that in quite a short time, we have been able to set up a variety of services. I mean, we develop an app for patients. We set up databases for advancing clinical research, both with routine patient data, as well as with data that was assessed as part of prospective studies. But yes, IT may help us to reduce the risk of burnout when IT systems actually facilitate workflows compared to traditional paperwork. But IT, as you said, itself may also at the same time be a major contributing factor for clinician burnout, as we have heard just from what Simon and Helen said. So if you ask me what the reasons are, in my opinion, a very big issue are poorly designed user interfaces that sort of patronize users. I mean, when users are forced out to fill out mandatory fields because they just can't save the documents without them, but it just doesn't make sense to fill them out. I mean, this causes frustration. And secondly, poorly designed interfaces may be the cause where things take just too much time. And if things take too much time, this may result in extra hours that clinicians may have to spend at the hospital. And once again, this may lead to frustration. So I think the root of the problem is that for quite too long, these kind of workflow and design aspects have not been part of benchmarking clinical information systems. I mean, when you take the decision to go with a new IT system, it's easy to look at the costs. It's easy to look at server capacities that you may need, but it's not that easy to really to see what it takes to make the lives of clinicians easier, or coming back to clinician burnout, harder. So, and last but not least, it's also about education. I mean, after all, doctors and nurses are trained to work with patients, not with computers. But computers is what they spend an incredible amount of time with.
I think you bring these issues out really quite well. I mean, I remember in hospital having to cope with the wonderful sea of red flags, which we used to get faced with filling all the, some of them really quite unurgent administrative tasks. And we didn't really have the ability to discriminate between the important and the less important. And also the fact that EMRs don't necessarily always follow clinical flows. They follow administrative flows, and the thinking and the process is very, very different. So I think you've really brought that out, absolutely, and hopefully that is changing, or at least I certainly live in hope that it is changing. I think it is. Frederick, in Skåne, you know, you are responsible for a major EMR deployment. I mean, affecting what, 10,000 nurses, 500 physicians. How do you sleep at night worrying about this?
I don't sleep at all. No, of course I sleep, but sometimes I'm a bit stressed. I am. But what we have trying to do is to take the knowledge and what you're describing from other members of the panel to when we design and configure our system, we try to use, we have a very high level of physician involved and nurses. Actually, if the project right now is have members of 350, 70% is have been physicians, clinicians, nurses the last year. So and we have a very high, we have special governance around, for example, alerts. You can put a massive amount of alerts in this system, in the Cerner system. I have heard about others who have 900 of them. We are free right now, and we have a huge debate because everyone likes these alerts. It's great, it's patient safety. Yeah, but when you have thousands of these alerts blipping all the time, you get burned out and stressed, and figure out which of these pop-ups is the important ones, or which is just, oh, don't remember to have lunch. That's maybe the most important pop-up, but that will never show up. So it's, we are trying to have a very high involvement of clinicians, from med techs to nurses to physician, all over the program, to make sure that we configure it. And the administrative guys who likes all these reports, we have them in different buildings far away, and they have to, the idea we have that they create behind back office the data they need to report to regulatory center authorities and so on. We don't know if we will succeed. We have 1 year to go live, but so far we are very happy with the results. And we also use, for example, we already started to train our physician and nurses in voice recognitions, and so they have all these in advanced. Yeah, I could talk for hours, so I stop there.
No, I think what you describe is really useful. Really, the challenge of designing an EMR really with the clinician in mind. And really the approach you're taking is actually putting the clinician close to the driving seat. It's not only the clinician that needs to be in the driving seat, but the clinician doesn't need to be right at the back. And in the past, perhaps, the people who designed these products were not necessarily having physicians in mind using their products as much as the administrative flows that go with it. I think you demonstrated that perfectly. And it's a perfect segue because I'll go back to Helen. You know, the drive to reduce stress on clinicians and the risks of burnout, you know, are not new, and we've just been talking about them. And the implementation of solutions to them is something we could talk about for the rest of this panel quite easily, because there's so many people who've come up with ideas. But it really would be interesting to hear how you have managed this in Birmingham, because I really think there could be some lessons to learn for us here.
Well, I guess we probably haven't done anything too different to a lot of other hospitals, but our solution to burnout is not necessarily an IT system type approach. It's more about the human being and the person behind it and staff support. So it's about our staff support and their well-being, and we, and I'm sure many hospitals, have put in support lines, we've put in well-being rooms, we've put in employee assistance, we've got health hubs, we've got counselling services, we've got what we call a wobble room, which is just a 5-minute outbreak room that we've put about the hospital. There's listening hubs. We've got, I think a lot of hospitals have the freedom to speak up guardians. They've been central to this. We've set up something called First You, which is, it's a staff forum where we're trying to deal with their grief, with keeping them in the community, because this is quite isolating, giving them inspiration and things to drive them to want to do a good job, trying to get them to think about their own lifestyle and things like that. Mental health support has been massive, and I can only imagine we've taken the tip of the iceberg on the mental health support, and for the future that's going to be a very big thing for us to cross with our staff. We put in home worker support, we've done domestic abuse for our staff, support teams. We do monitoring, we do dashboards that monitor their sickness so that we can see trends, because there will be people who show their stress levels by being off sick, but there'll also be people that show stress levels by going off sick for non-genuine reasons. We allow staff to move around. We concentrate very hard on recruitment and recruiting the right job to the right people. And just because you've been recruited into a job and it hasn't actually worked out for you, that's not a failing. There are other posts in a trust this big. There are always other opportunities for people. So, you know, we try to find a place for them. We do exit interviews to try and find out why our staff, why they leave the trust, but why are they leaving the NHS? Because some people are doing both. We have our own sports centre, so we've got a staff swimming pool and things like that. So we're very spoilt from that point of view. On a monthly basis, we have something really simple, which sounds really silly, but we have a farmer's market in the entrance of the hospital, which is just lots of stalls with nice things on it. They come once a month, and the staff, the relatives and the patients love that. We have a fruit market outside the hospital, which is there every day, which is encouraging the staff and the visitors to try and eat healthy. We do award ceremonies. So our staff do what we call the Best in Care Award. We have a staff physio service. So our staff don't have to necessarily go through the GP route to get a physio appointment. They self-refer. We have an orchard where we grow our own fruits and things. We have clothing banks and food banks that the staff bring things in that makes them feel like they're contributing to the community.
I mean, this is an enormous amount of stuff. But basically what you've done, what you've demonstrated is you have shown that one, people are valued, and that's really quite important. And secondly, that you've given opportunities for that value to become tangible. And I think those are the two most important issues. And thank you very much for sharing that, because there are some ideas here which can be used by other people. The wobble room, I love. You know, there's lots of things we can be doing. Simon, you know, we're talking about technology here. You know, can we actually leverage technology to relieve the pressure on workforce? And doesn't actually end up adding another layer of complexity? Because I've also sadly seen this happen, whereby we use some technology to solve a problem, and all we've done is shift the problem somewhere else.
Well, I think we can. And I think artificial intelligence has a role to play in reducing the admin burden that clinicians face in their day-to-day activity. And perhaps I could focus on the challenge I set earlier around clinical documentation. Frederick mentioned speech recognition. And what do I mean by that? Well, essentially anywhere that clinicians are typing into their EPR or dictating a letter, they can instead use their voice and see that text appear real time on screen, what we call dictating at the point of cursor. Again, not just for doctors, nurses, allied health professionals can benefit, and not just in the acute sector, those working in primary care, the community, and also in mental health. the technology has come on in leaps and bounds over the last few years, and I think that's key for clinicians feeling comfortable using it. It's now accurate and able to identify very well those complex medical terms and drug names. You know, as you hinted, technology is a waste of time if it's not going to if it's going to add even more stress to the clinician's workflow. But with speech, well, we speak 3 times faster than we type, so it's faster. Now there's no initial training of your speech profile. It can be used straight away. And because it's in the cloud, you can have access to your voice profile wherever you may be, so it makes it much more convenient. Does it work, and does it reduce stress in the workplace? Well, I think it does, and the feedback we've had from clinicians is it does have time savings compared to typing. It reduces delays and improves that flow of communication. And actually, it improves the quality of the content of the patient record. And we found that particularly in the outpatient setting and in ED. And one particular clinician, after having changed his way of working, said that he felt it had reduced his admin burden, and actually he could get home to see his kids, which before he was staying late to do things. So if we then look a little bit to the future, what can you build on with speech? Well, natural language processing allows a number of extra tools of things like improving a clinical term, being able to SNOMED CT code on the fly as you create your note, and accessing knowledge databases like UpToDate or BMJ Best Practice at the time you're actually creating your documentation. What's the ultimate vision? I guess it's the clinic room of the future using what's called conversational artificial intelligence. So that desktop computer completely disappears and it's replaced with a smart device with multi-microphones and sensors. And voice biometrics allows you to sign in just with your voice. My voice is my password. The voice biometrics also distinguishes between the patient speaking and the doctor speaking. And the whole note is diarized. And what's called virtual assistance allows you to take the clicks out of the EPR and say, show me the latest CT scan or start my knee pain pathway, and do that automatically for you. And then
so I can throw this away, can I? I can throw this away.
Yeah, say again, sorry, Charles?
Can I throw this away?
Yeah, if you're referring to the desktop, ultimately what it is that there's no more typing, no more clicks, no more back turn to the patient hunched over the computer, and that speech and artificial intelligence actually does a lot of the grunt work behind. And I think this sort of technology will play a role in reducing the admin burden and hopefully relieving the stress and burnout that the healthcare profession is enduring at the moment.
Yep. My God, will that make a difference? So gone will be the days of somebody sitting next to you and you not looking at them and actually typing away as you're contemporaneously putting on your clinical notes.
That's right, a much more face-to-face engagement.
Well, this is what a lot of us became doctors and nurses to do. So this is exactly in the right space. So, Felix, we talked about the potential of this new world. It sounds like something out of science fiction in terms of the ability to be able to do this. And what do you think are the key characteristics of software regarding future deployments that will help with burnout?
Sure. I mean, COVID-19 was a great example on how important it is to streamline documentation processes. I mean, for example, as an intensivist, you need to know what has happened to your patient also before he came to your ward. So what has happened to him in the outpatient clinic, on the regular ward, etc. So the thing is, we just can't impose on our clinicians to work with multiple IT systems at the same time. I mean, if you have to copy and paste data among systems, this causes frustration. So what do we need to improve? Basically, key is that the retrieval of data is really easy. I mean, it has to be accurate and timely. And when it comes to the presentation of data, it must be simple and intuitive. I mean, if you need a written manual for software, then something is definitely wrong. And also, software must be reliable. So if there's an expected downtime, for example, this is something we plan really carefully ahead so that everybody knows, is aware of it and knows what to do on the ward. And last but not least, if I had to choose one particular aspect on how to improve clinical software, this would be to include clinicians in the development and the implementation of the software from the very beginning. And for us at Charité, this proved to be quite a good strategy.
Well, I mean, getting people from the start to be engaged is clearly going to be one of our solutions. So thank you very much for that. I'm just going to bring Frederick in, but I'm going to come back to you straight after Felix, and I'll go around all the panelists after as well and ask them to give a single thought to get you start thinking now around something for our audience to take away. The whole basis of all these meetings and these webinars is really to share knowledge, to share best practice, and also to share things which didn't go as well as we thought they would go. Because the only way we learn is by sharing our experiences. So I'll come back to you. So start thinking, Felix, while I go to Frederick. So Frederick, you already have a digital EMR in place. And you're in the process of implementing and deploying an even more modern system. Now, the first question I would ask if I were a practicing physician in Skåne in Sweden is, you know, how are you going to ensure you don't add extra complexity to my life rather than anything else? I mean, how are you going to assist physicians here?
That's a tricky question, and sometimes I doubt that we will have a success in that manner. But what we are trying to do, what we actually do, we will close down 50 systems. Today we use 50 different systems to have patient information. It's divided in this 50 system: one for lab, one for sending the lab, one getting the report, and so on. So by closing down these 50 systems to one single point of contact actually for all patient information, we really hope that we will decrease the burnout. All these, when you try to find a result, try to find even the patients, to find a phone number to a patient, it could be displayed in 4 different systems. Which one is the correct? So that's how we think about it, and I really think what we are trying to do is to also starting this adoption that Simon also and Felix also mentioned, to move this from the desktop, move it from speak recognition, starting to use the artificial intelligence in, for example, when you're creating your notes. Because I think it's very important also that they structure the data so we can reduce it. To answer the question in the chart every time, is it a smoker or non-smoker? It's easy if it could be used type 1 and reused all the time. That will also lower the burden, and we will also make sure that we have more accurate data. So by combining these, we are trying to make it more smooth for the physician and nurses. But when you change system, it's always tricky. And it's also about a form of generation. For example, my daughter, she's 15. She walks around her iPhone and discussing with Siri about the election that will take place in the US about Trump. But she asks Siri questions, and I say, hey, what are you doing? Who are you talking to? Oh, I get information about Trump. What he said on the Republican convention. So this is also about the form of generation, and that's maybe even in some cases rise the stress and the burnout. So we need to be very flexible how we look at this, and maybe we should have different for different. Yeah, it's incineration also that we need to have that in mind.
I think you're absolutely correct, Frederick, because what you bring out is the demand on clinicians during consultations, during interactions with people. Not only are they having to remember the pathways, no longer remember exactly how to actually deliver care and also care for the individual, but also annotate it. And this is a real challenge. So the thought of actually doing this in one place is potentially an enormous advantage, if, of course, the interface is the interface which would work. And that is always the biggest challenge, of course, because we know how easy it is to set out something in theory, but in practice, oh wow, it is far more difficult than that, really, to come up with a solution. So thank you very much for that. I think, you know, we could go on for the next few hours, but it would be helpful perhaps for us to think in terms of giving a final message to people. As I said, this is really important. A couple of sentences, no more than about a minute or so. And I'm going to start with you, Felix, as I said I would, and then I'll come to you, Helen, so you're warned that you're going to be the next, and then Simon, and then back to Frederick. So, Felix, just your final thoughts.
Sure. My final thought would be empower your users. Don't just ask your clinicians what they want, put them also in charge, and really put them in charge, give them responsibility for both the development and the implementation process.
Yes. Wow. What a thought to remember. And I think that's really important, and that will have a significant effect. Helen?
I would say that if you were implementing an IT system, don't stand still. So even though you might have implemented it today, it doesn't mean to say that in 6 weeks' time it's going to be up to date, it's going to be accurate. You've got to be prepared to invest. You've got to be prepared to change. You've got to be prepared to revisit the system that you've developed and change, you know, rewrite it if you have to. But the world changes, patients change, healthcare is changing, and your IT systems cannot stand still and become out of date. Otherwise, it's just another stressor for the clinical team.
Yeah, and the catch-up is probably even more of a stressor, Helen, when you have to catch up, because you've got a bigger path to jump across. Absolutely correct. Simon?
Well, clinician burnout and the COVID crisis are the top two priorities for healthcare in every country. With respect to digital technologies, there is good stuff out there, but let the clinicians guide the organizations about it being fit for purpose and actually improving workflow, increasing the quality of care and patient safety, and ultimately playing a key role in reducing stress and burnout in our clinical community.
And that is exactly the same message refocused and reframed in the world of COVID. And I think having, you know, the physicians close to the center in the way these are designed is something which is coming out loud and clear. We ignore workforce at our peril, as Frederick has told us already. And back to you, Frederick.
Yeah, I think my take, make it easy. Only do things that's necessary, not because it's nice, because we like to put things that's nice, but what's necessary, what do we need to do our job as clinicians? Nothing more than that, only that.
Oh, well, now that's an interesting comment, which I'm sure will be taken up by our RT specialists, or how did Helen call them? The geeks? No doubt they'll feel really quite unhappy about not being able to do something just because they can. But I think that's very, very wise. So thank you. And finally, can I thank you, the audience? Thank you for listening to us today. And thank you to Nuance as well for assisting us in getting this session together. Thank you, Simon. Thank you, Helen. Thank you, Felix, and thank you, Frederick, for sharing your expertise with us today, and our audience for joining us. We hope you've learned some valuable lessons. And if you'd like to continue with this discussion, please join the chat room below, where you can speak to the attendees and speakers on the same page. And finally, of course, I'd also like to thank all our healthcare professionals who are still on the front line, still continuing to fight the fight as we go through these difficult times with the pandemic. So thank you, all of you, for attending today. Thank you.